Welcome everyone to ISGyP Live Journal Club for October of 2020. My name is Natalie Benet. I'm the moderator. This month's theme is Ovarian Serous Neoplasms. The objectives of our journal club are to engage trainees in gaining scientific knowledge and ability to critically evaluate the literature, to offer opportunities for trainees and young members from all parts of the globe to volunteer as presenters and moderators, to provide mentorship and to engage the future leaders of our field around the globe. And I just want to emphasize that this is an inclusive space, that the folks presenting are trainees, and that these topics this month and every month are complicated, and we're going to make an effort to make sure everyone learns, and questions at the end will be answered sort of to the best of our abilities, with me and the presenters answering together. So this month's theme is Serous Neoplasms of the Ovary. These are the 3 articles which we will be presenting, and our trainees will tell you more about them in just a moment. I'd like to introduce this month's presenters. We have Dr. Hansini Laharwani. She is a 3rd-year pathology resident at the University of Mississippi's Medical Center and has future plans for a GYN and breast fellowship at Washington University in St. Louis. We also have Dr. Diana Jaravaza. She is a 4th-year anatomic pathology registrar in Tygerberg Hospital, Cape Town, South Africa. And we also have Dr. Lisa Hahn. She is the current GYN and breast pathology fellow at the University of Chicago Medical Center. And this month, all 3 of our presenters are new presenters at GYN Pathology Journal Club. So I'd like to welcome them and thank them for their hard work. We've already reviewed their presentations, so I know that you all are in for a good hour of learning today. So the schedule after my intros will go straight to the first presentation, then the second and the final, each taking about 15 minutes. In between each, schedule permitting, we will have a polling question, but I'll walk you all and the presenters through that information. And then we'll have time for wrap up and discussions and questions at the end. Just to review quickly that this is a webinar format through Zoom. So if you haven't used it before, the Q&A function is at the bottom of your screen in that black bar. So if you click there, you can type your own question in, or as I've indicated with that second arrow, if you like someone else's question, hit that thumbs up button and I'll be able to tell that that question is more popular and try to prioritize those types of questions. The chat function can be used to offer feedback. We do save that information and pass it along to the presenters at the end, but if you could please not put your questions there. It becomes a little hard for me to monitor both of those spaces within the meeting. So now we will go ahead and get started.
Good morning, everyone. Firstly, I would like to thank you, Dr. Bannett, for a wonderful introduction. And the topic of my journal club is Clinicopathologic, Immunohistochemical, and Molecular Characteristics of Ovarian Serous Carcinoma with mixed morphologic features of high-grade and low-grade serous carcinoma. So in this study, the study design of my article was to describe the morphologic features of the relatively uncommon group of serous carcinoma, which is the indeterminate grade serous carcinoma. And that indeterminate grade serous carcinoma has mixed morphologic features of both high grade and low grade. And so the design of this article was to investigate the immunohistochemical, molecular, and clinical characteristics of this diagnostically challenging group of ovarian epithelial neoplasm. And it is important because treatment for low-grade serous carcinoma and high-grade serous carcinoma, it differs at early stage, and therefore it is very important to correctly identify them. So this study was performed at Mayo Clinic Ovarian Cancer Tumor Repository, and 650 cases were selected from 1995 to 2012. Amongst those 650 cases, 476 cases were classic high-grade serous carcinoma, 31 were classic low-grade serous carcinoma, and 22 were indeterminate grade serous carcinoma, in which high-grade areas apparently coexisted with low-grade serous carcinoma, including 2 cases in which had this ambiguous high-grade serous morphology that resembled the high-grade areas in the other 20 cases, but a definitive low-grade serous carcinoma was not identified, and it was difficult to classify. All these cases were reviewed by one GYN pathologist who reclassified them as per the WHO 2-tier classification system. And tumors were either from the METs or primary tumor site, but all were from the same time of the debulking surgery. None of the patients had received either neoadjuvant or adjuvant chemotherapy or radiotherapy before debulking, and all of them were first time, and all the first time diagnostic material was reviewed. So most of the patients in all the three groups were diagnosed at stages 3 and 4. In that, 92.3% were classic high-grade serous carcinoma, 89.5% were indeterminate grade serous carcinoma group, and 73.7% were classic low-grade. A small number were diagnosed at earlier clinical stages of 1 and 2. In that, 7.7% were classic high-grade, 10.5% were indeterminate grade serous carcinoma, and 26.3 were classic low grade. But as you can see, the p value was not significant and it was only 0.42. So this was a really nice chart in that article that summarized the IHC results. And as you can see that, in the classic low grade, the mutant patients were 0, wild type were 19, classic high grade mutant were 12 patients, wild type was only one patient. And then for the most important thing is the indeterminate grade serous carcinoma. Here we see that, in that it had identical mutations in the low and high grade, while other areas just had like one expected like gaining of p53 mutations. The most common thing in this indeterminate grade showed that out of 19 patients, 13 times there was no p53 mutation at all, with that caveat that the authors mentioned that they did not sequence the entire p53. And as per the article, although most of the documented p53 sequences were suggested in the high grade and they did fall within the hotspot tested regions, they did not demonstrate a high concordance with the IHC expression pattern. And so the study cannot exclude that some of the tumors, especially the clinically aggressive indeterminate grade and other mechanisms that lead to T53 alterations or alteration of genetic phenocopies. So this is very important because it is tempting as a pathologist to equate wild type of p53 with non-high grade or aggressive behavior, but these patients had a worse outcome at 5 years than the high grade group. And the NGS panel that they used in this article, it did not find the mutations in most of these tumors. So they did acknowledge that there is still more work to be done. So in the molecular results of the 13 high-grade tumors, all 13 were found to have somatic T53 mutations. In the classic low-grade, we all know that the common mutation is KRAF, which is 27.8%, followed by NRAS and BRAF non V600E and ERBB2. About a third, that is 33.3%, they did not show any genetic alteration by the sequencing panel. Most of them, which is 66.6%, indeterminate grade serous carcinoma, had mixed morphologic features of high grade serous and low grade serous. They did not show any mutations by the NGS assay, covering the mutation hotspot regions in the 50 commonly mutated genes in the solid tumors, like I mentioned before in the earlier slide. The most common mutation which was seen was T53 in both high grade and low grade components, in 3 indeterminate grade serous carcinoma, and in 1 case with only ambiguous high grade morphology. 1 case had NRAS mutation, and 1 additional case with only features of high grade serous carcinoma showed mutation in BRAF. So this is the microscopic view of a low-grade serous carcinoma, and in this image we can see these irregularly shaped small nests of cells which are haphazardly infiltrating the stroma, some micropapillae, some macropapillae, which have an undefined clear space. And we also see in image A semoma bodies, and the image C we see is a corresponding mutant BRAF V600E immunostain. This is the microscopic picture of a classic high-grade serous carcinoma, and as we all know, the high-grade serous carcinoma, they are typically composed of solid masses of cells with slit-like spaces. They also have papillary, glandular, and cribriform areas. They can have necrosis, and we know that the nuclei are very large, hyperchromatic, and mitosis are numerous and typical. And the image C, we see that the P53 stain, the mutational, and it is like diffusely, it is a diffusely mutational P53 immunostaining pattern we see in image C. And here we come to the hard part. This is the inter indeterminate grade serous carcinoma. So it has architectural features of low grade serous carcinoma, but if you look carefully at the nuclear features, the nuclear atypia, it clearly points towards the high grade serous carcinoma. And if you see the immunostains in B and D, we see that the immunostains, they were equivocal in B and they were wild type in the low grade. So this is the most difficult part of indeterminate grade serous carcinoma. So, thus, the discussion is that the study does provide information regarding rare cases of serous carcinoma, which are difficult to classify by the conventional two-tier system. And indeterminate grade serous carcinoma is a rare, but it is a morphologically distinct tumor that provides a diagnostic conundrum for pathologists within the existing two-tier grading system. These tumors have morphologic characteristics that make them difficult to assign either high grade or low grade, because it is characterized by a mixture of both high grade and low grade morphologic areas, or sometimes rarely homogeneous micropapillary or solid morphology that is cytologically monotonous and less mitotically active than the classic high grade serous carcinoma. Molecular analysis suggested that defined intermediate grade serous carcinoma infrequently show P53, RAS, ERBB2 mutations, which are typically seen in classic serous carcinoma of high grade or low grade, but are negative for these alterations. Although a very small number in this study, T53 mutant intermediate grade serous carcinoma may actually have an aggressive course than classic high grade and P53 wild type. Indeterminate grade, they still pretend a clinical course similar to high grade serous carcinoma. Thereby, it was a diagnostic pitfall, especially in small biopsies. And because of the lack of common mutations and predicted clinical course, it is important to recognize indeterminate grade serous carcinoma, because it may prompt oncologists to order larger NGS panel that may help earlier in the treatment course for these patients to characterize the molecular profile and open potential therapeutic options and opportunities for clinical trials. I felt the strengths and areas for improvement in this article was that there need to be a more structured microscopic evaluation of low-grade serous carcinoma, indeterminate grade serous carcinoma, and high-grade serous carcinoma with the morphologic findings. The it is a rare entity, and so the case number was very small. The other finding which was lacking was that a full sequencing of the T53 gene. They did not sequence the full T53 gene, and this study did not take into consideration the features after neoadjuvant therapy. They only took into consideration the patients that did not receive any radiotherapy or chemotherapy. I feel that they should have also taken into consideration what happened to the patients that received the chemotherapy, what was the morphologic characteristic of those tumors. Applications, I feel that these cases are uncommon, but they do pose a diagnostic dilemma which impacts treatment for patients. The morphologic analysis gives us guidance on how to handle these cases, and definitely we need additional testing with IHC and molecular, which are also described for facilities which have limited capacity and resources. Studies such as this are important to understand those high-grade serous carcinoma that do not arise from a common precursor lesions. And some cases of high-grade serous carcinoma arise from serous borderline tumor or micropapillary serous tumor. They do not have TP53 mutations, but they still have a poor prognosis. And important is that in small biopsy material, there can be some aberrant P53 staining, especially in those aggressive tumors. So we have to take into that also consideration. And it is important that if there is early testing of these tumor, it is important so that they can they can find targetable mutations. Thank you.
So you all should be able to see the first polling question in the audience regarding this article. So you should be able to see the results now. So the question was, which of the following is true regarding the group of intermediate, or it should be indeterminate grade, serous carcinomas described by the authors in the study? And let's see, the answer was they generally showed architectural features of low-grade serous carcinoma with the presence of higher-grade nuclear features. That was commonly noted. The first answer that these indeterminate grade serous carcinomas, or IGSCAs, were not common. Like Dr. Laharwani noted, they were uncommon. The sample number was low, even with this giant cohort that they started with. The patterns of stromal invasion in this group have been described before. So that question is not true. And then they did not show genetic alterations identical to high-grade serous carcinoma, which she also reviewed.
All right, good afternoon. My name is Diana, and the article I was tasked to look at is entitled Characterization of TP53 Wild Type Tuber Ovarian High-Grade Serous Carcinomas, Rare Exceptions to the Binary Classification of Ovarian Serous Carcinoma. So all four authors are from Memorial Sloan Kettering. So as a backdrop to this article, we know that tuber ovarian serous carcinomas are divided into low-grade and high-grade based primarily on the presence of TP53 mutation in the high-grade variety, as well as severe nuclear pleomorphism and the features detailed in the table. So this article set out to, or the study aimed to review a subset of reported TP53 wild type, but also high-grade tuber ovarian serous carcinomas, and to just describe their morphological, immunohistochemical, and molecular characteristics. So they had 1,017 cases that had been profiled on their molecular platform. And from those cases, they found 25 TP53 wild type carcinomas. Their morphology was consistent with high-grade serous carcinoma on review. In most cases, they were preceded by serous tubal intraepithelial carcinoma, commonly known as a stick lesion. Their immunohistochemistry profile was compatible with the high-grade serous carcinoma. And the investigators proposed that these TP53 wild type tumors be divided into two groups. So the first group is the usual high-grade serous carcinoma-like group, typified by grade 3 nuclear atypia, with downstream evidence of TP53 dysfunction despite being TP53 wild type on molecular. The second group they propose is the low-grade serous carcinoma-like, with grade 2 nuclear atypia and micropapillary features, and also having RAS or BRAF mutations. So other mutations that were found in this group of cases were BRCA1 and 2 mutations and CCNE1 mutations. This group also showed intermediate chromosomal instability between low-grade serous carcinomas and high-grade tumors. So their inclusion criteria was that these tumors had to have been TP53 mutation negative on the institutional mutational profiling platform. They also selected 35 consecutive TP53 mutated cases. So all these cases had histological review performed by two gynecologists who were blinded to the mutational status of these cases during review. And the morphological data that they collected included nuclear atypia, the morphological growth patterns, and the mitotic rate. During this part of the study, they excluded cases with from patients who had had neoadjuvant chemotherapy. So they ended up with 55 TP53 mutation negative cases, but on review, 30 cases were excluded for reasons of low tumor content, variant TP53 mutations, or the tumors were reclassified as low-grade serous carcinomas or endometrial carcinomas with metastasis to the fallopian tubes or ovaries. So their final cohort was that of 25 cases, and All of these cases had fallopian tubes reviewed by a single pathologist looking for a precursor lesion. Immunohistochemistry was performed on formalin-fixed paraffin-embedded tissue, included P53, WT1, and PAX8. And next-gen sequencing was used to identify germline variants, and manual review of somatic variants was also done to identify unusual ones. So the features of this group of 25, so the median age of the patients was 62 years, and the majority presented in the late stages 3 and 4. 24% had received neoadjuvant chemo, and the average follow-up interval was 44 months, with the majority of patients still alive but with disease. So when they compared this group of TP53 wild-type tumors with the traditional TP53 mutated tumors, they found that grade 3 nuclear atypia was not found in all of the cases, unlike with the TP53 mutated tumors. Micropapillary features were more likely to be found in the TP53 wild-type group, as were micropapillary architecture together with grade 2 nuclear atypia. And we know that grade 2 nuclear atypia is not, by definition, found in TP53 mutated tumors. There was no significant difference in a mitotic count of 12 or less between the two groups. Germline mutations in BRCA1 or 2 or PALB2 were found in some of the TP53 wild-type tumors. And as mentioned before, TP53 wild-type tumors showed intermediate chromosomal instability. So the investigators proposed that these TP53 wild-type high-grade serous carcinomas be divided into the two groups, the low-grade serous carcinoma-like, showing features similar to the traditional low-grade serous carcinoma, and the usual high-grade serous carcinoma group. And the basis of classification would be the presence or absence of BRAF, KRAS, or NRAS mutations, which would define the low-grade serous carcinoma-like group, or grade 2 nuclear atypia in combination with micropapillary features. All the others would then have grade 3 nuclear atypia or none of the above mentioned mutations and would fall into the usual high-grade serous carcinoma-like group. And their reason for this proposition was the findings as detailed in the table below. So most low-grade serous carcinoma-like tumors were preceded by previous low-grade lesions like serous borderline tumors. Nuclear atypia was found, grade 2 and 3 nuclear atypia were found in all of the usual high-grade serous carcinoma-like tumors compared to the low-grade ones. There was a significantly higher rate of a stick lesion or mucosal involvement of the fallopian tubes in the usual high-grade serous carcinoma-like group, 91%, as compared to 43% in the low-grade serous carcinoma group. Then when it came to immunohistochemistry, 11 of 23 cases showed P53 wild-type staining, and 78% of low-grade serous carcinoma-like tumors showed the staining, in comparison to a lower figure of 29% in the high-grade serous carcinoma-like group. None of the two groups showed cytoplasmic or mutant staining. So these photographs just demonstrate the morphological spectrum that was seen in the low-grade serous carcinoma-like tumors. And this second image demonstrate the features found in usual high-grade serous carcinoma-like tumors, as well as the pattern of P53 staining in stick lesions. So the background to the study is that there's controversy regarding whether ovarian high-grade serous carcinomas can indeed be TP53 wild type, because it has been understood that TP53 drives high-grade serous carcinoma. Some authors have proposed an intermediate or indeterminate grade serous carcinoma. There were some cases that were picked up on the Cancer Genomic Atlas study, but when they were reviewed, most of these cases were shown to have been misclassified as high-grade serous carcinomas in the first place. So this study is the largest cohort to date. It combined a concurrent molecular and histopathological review, and importantly, investigators were blinded to the mutational status of these cases when they performed the histopathological review. In terms of strengths, I do think that the study provides evidence for a third group of tubal ovarian serous carcinomas. That is an intermediate group that shows features of both low-grade serous carcinoma and high-grade serous carcinomas. And in addition, they provide compelling evidence for subclassification of this group of TP53 wild-type tumors into two subgroups. They also propose that different pathways could be responsible for TP53 wild-type tumor pathogenesis, and that low-grade serous carcinoma might indeed be a precursor. We know that low-grade serous carcinomas rarely progress to the traditional high-grade serous carcinomas. This study used a higher sensitivity sequencing approach and rigorous quality control, which suggests that the cases in which they found aberrant P53 staining are actually represent true aberrant P53 staining, and that this can occur in high-grade serous carcinomas in the absence of TP53 mutations. This would suggest alternative pathways, for example, MDM2 amplification. The study demonstrated thorough histological and mutational analysis with appropriate blinding. And importantly, the investigators emphasized that histomorphology remains the crux of the high-grade serous carcinoma diagnosis. However, the sample size is low and further research is required before these findings can be extrapolated. We still need to know the reasons behind aberrant P53 staining in some of these cases. In addition, germline mutations in APC and MUTH, which we know are colorectal cancer-associated genes, were found in some of these cases, but the reason remains unknown. In terms of applications, I believe for now it's mainly academic. The implications on patient management and prognosis are yet to be clarified, as the follow-up interval in the study was only 44 months. The important thing is that morphology remains the key for distinguishing low-grade serous carcinomas from high-grade serous carcinomas. P53 immunohistochemistry is useful, but we must remember that there's a pitfall in the wild-type staining pattern, which may still represent high-grade serous carcinomas. Importantly, mutational analysis may not be accessible at many centers. Thank you.
Thank you. Thank you for sharing those pictures. Lovely. The question was, the authors found two subgroups within the TP53 wild-type tumors, one of which they designated low-grade serous carcinoma-like. Which of the following is true of this group? And the answer was that these tumors show mixed morphologic features of low and high-grade serous carcinoma and presumably evolved from low-grade tumors. The first answer, none contain mutations in KRAS, BRAF, or NRAS, is not true. The idea that all contain mutations in TP53 is also not true. And they did contain micropapillary architecture in conjunction with grade 2 nuclear features. At least some of the cases did. So that answer is also not true. So I think most of the audience, it seems like about over 3/4 found that correct answer.
Thank you, Dr. Bennett, for this opportunity. And today I will be talking about this article titled Intratumoral Heterogeneity Accounts for Apparent Progression of Non-Invasive Serous Tumors to Invasive Low-Grade Serous Carcinoma, a study of 30 low-grade serous tumors of the ovary in 18 patients with peritoneal carcinomatosis. So most carcinomas progress in a multi-step process where carcinoma in situ is followed by superficial invasion, vascular invasion, and metastasis. Given this dogma, it has always been perplexing that non-invasive low-grade serous neoplasms of the ovary often progress to disseminated carcinoma in apparent absence of extra-ovarian disease. So this study seeks to provide a way to answer how do a small proportion of non-invasive low-grade serous tumors of the ovary progress to invasive low-grade serous carcinoma at a low but regular rate. A possible theory is occult invasion that was undetected because of insufficient sampling of the ovarian tumor. Another explanation could be that ovaries and fallopian tubes' direct access to the peritoneal cavity allow for exophytic tumor to shed and implant on peritoneal surfaces without invading underlying ovarian parenchyma. Still, other theories include tumorigenesis from endosapyngiosis and new primary extra-ovarian disease. The question the study is ultimately trying to answer is, does increased sampling detect more overt carcinoma, which would support this first theory? Here's a review of the way we classify low-grade serous neoplasms. A couple of things to emphasize: if there is no invasion and less than 10% micropapillary architecture characterized by non-hierarchical branching, the tumor is referred to as a serous borderline tumor or atypical proliferative serous tumor, APST, which is a terminology I will hereon use in this presentation since this is the language of the authors. If there is less than 5 millimeter span of microinvasion characterized by these eosinophilic cell clusters without a desmoplastic reaction, we call it eosinophilic microinvasion, which can be distinguished from microinvasive carcinoma, where the invasive focus consists of micropapillae, inverted macropapillae, or cribriforming glands spanning less than 5 millimeters. The authors selected cases from 1991 to 2013, consisting of 30 cases from 18 patients who had disseminated peritoneal low-grade serous carcinoma. They conducted a complete slide review of the ovaries and extra-ovarian disease. And they recorded number of blocks per centimeter of tumor, number and size of microinvasive foci, etc. Tumors were evaluated under hypothetic scenarios where sampling was stopped at 1 section per centimeters or 2 sections per centimeter based on original numerical order of sections. So table 1 shows the clinical pathologic features, including number of microscopic sections evaluated in all the cases. The non-invasive ovarian component consisted of 15 APSTs, 11 non-invasive low-grade serous carcinomas, and 2 adenomas. The mean percentage of blocks per tumor containing overt carcinoma was only 27%. Of note, only 10 of these 30 cases were sampled at 2 sections or more per centimeter. Table 2 demonstrates the diagnosis of each tumor under the hypothetical condition in which sampling was assumed to have stopped at 1 and 2 centimeters, 2 sections per centimeter, and beyond. When sampling was increased from 1 to greater than 2 sections per cm, 2 APSTs were upgraded to APSTs with microinvasion, and 4 microinvasive carcinomas were upgraded to overt carcinomas. Eosinophilic microinvasions was always associated with microinvasive carcinoma, but never alone. The authors also observed that the calcifications were more often associated with presence of invasive carcinoma. The central argument that the study is trying to make is that metastasis as extra-ovarian low-grade serous carcinomas may often be due to occult primary invasive carcinoma. The authors make the case that increasing sampling to at least 2 sections per cm and the presence of any type of microinvasion should prompt further sampling to identify overt carcinoma. Eosinophilic type microinvasions, as demonstrated in this figure, was identified in 30% of cases and was never seen alone. This is corroborated by prior studies suggesting that these eosinophilic cells may be senescent or apoptotic cells with BRAF mutations, which are less likely to be found in patients with recurrent low-grade serous carcinomas compared to KRAS mutations. Thus, this type of microinvasion may actually be biologically insignificant. This is in contrast to microinvasive carcinoma, which were all identified in cases with overt carcinoma, overt ovarian carcinoma. Sections containing calcifications are significantly more likely to contain invasion, and so this could be a factor in hindering sampling and overlooking invasion. Finally, although 5 millimeter is the most common cutoff for microinvasion, all tumors in the studies with 3 to 4.9 millimeters of microinvasion had overt carcinoma, which perhaps mean that we should rethink this cutoff. The strengths of the studies included straightforward study design and providing a basis for increased sampling of calcified areas for invasions, which has not been elucidated in previous studies. There are also areas for improvement. Firstly, the title is a bit ambiguous. For me, the phrase intratumoral heterogeneity conjures up ideas about differences in molecular biology among different parts of the tumor. Perhaps a better title would be undetected occult ovarian invasion accounts for apparent progression of non-invasive serous tumor to invasive low-grade serous carcinoma. In the same vein, occult invasion may not be the only way to account for dissemination of low-grade serous carcinoma. And so this study serves more as a possible explanation rather than a biologic mechanism for this apparent progression. The lack of uniform grossing and handling of cases is important to note, which is difficult to address when we're dealing with a retrospective study. However, forming hypothetical scenarios where sampling stopped at 1 section per centimeter or 2 sections per centimeter implicitly assumes that the different residents and PAs grossing these tumors place sections with higher yield for invasion within the first few cassettes, which may not always be the case. Also, it isn't clear in the study whether multiple sections were placed in one block. Moreover, as I mentioned before, only 10 tumors were sampled at 2 or more sections per centimeters, which isn't surprising as grossing guidelines for APSTs in the 1990s were probably less thorough than those today. Additionally, the clinical relevance of this study, which consists of patients with already peritoneal carcinomatosis, might be less than if the study were to include stage 1 and 2 tumors. Finally, it would be very interesting if the study included a histologic review of the metastatic extra-ovarian neoplasms to correlate the patterns of invasions in both sites, that in the ovary and in the extra-ovarian site. So useful applications of the studies include increasing sampling of APST to 2 sections per centimeter or more. As mentioned before, when microinvasion is identified, we can increase sampling to find overt invasion. Gross foci of calcification should be decalcified and processed since they are associated with invasion. Eosinophilic microinvasion should prompt further sampling, but measurement of extent and reporting in the diagnostic line may not be necessary as they appear to be not biologically significant. Finally, this study supports rethinking the size cutoff for microinvasive carcinoma because those with less than 5 millimeter of microinvasive carcinoma are often associated with overt carcinoma. Okay, thank you. That is my presentation.
So the question was regarding the findings of this study, which led to recommendations for handling of non-invasive tumors, which of the following is true? And the answer is sampling of these tumors at 2 sections per centimeter should be considered, with additional sampling considered in cases with invasion. And the other choices were really distractors. And there is one question, and I don't know if Dr. Laharwani is still here, but it came in after her talk. And Dr. Jaravaza, this would also apply to your talk. Someone says, what an excellent talk. Were there any guidance or recommendations about how to sign out cases of indeterminate or intermediate grade serous carcinoma? Should they be classified as high grade in the 2-tier system? If either one of you wants to take a stab at that, you can. I'm also happy to answer the question. What would you do, Dr. Jaravaza? Or Dr. Laharwani, I know she had to run for a conflict, so.
Thanks. At the moment, there is no recommendation. I think this paper is proposing that there is an intermediate group and that further research is required. So it's not saying that there is a definite group and that we should start classifying tumors as being intermediate grade.
Yeah. Yeah. And it was interesting in, it was the, let's see, the other paper, the one from Mayo, Dr. Bell and her colleagues, Dr. Zarei, they comment that most of the cases which they designated as indeterminate were signed out initially as high-grade serous carcinoma with unusual morphology. And then there was a comment describing the microscopic features. And it seems to me, and this is not a new theme, if you go back, I tweeted it out, but when I was preparing for Journal Club, I ended up reading a lot of really like older papers. And it seems like this is a recurring theme that when you see nuclear atypia that looks like high-grade serous carcinoma, those cases really do perform differently. And like you said, Dr. Jaravaza, especially thinking about how this applies in a worldwide perspective, maybe in developing countries or countries where patients don't have the money to pay for molecular testing, it's really nice that morphology is still so important in these cases, and that if you do see that atypia which exceeds that which you would expect in a low-grade tumor, at least let your clinicians know that this has some features of high grade, because I think if they had to pick a path to put the patient on, they wouldn't pick the low-grade path, right? They would maybe treat them more like a high-grade tumor. Yes, and then let's see. A lot of people are thanking you all. And then Dr. Han, I don't know if your article, the only other thing I wanted to comment on is that you did an excellent job. There was one thing that I just wanted to show people because I find this to be confusing. This is just a brief summary of what the new WHO indicates, the 2020 WHO, about how to call these tumors. And the microinvasion versus microinvasive question is one that has been problematic, I think, not as of recently, it's been like this. And so microinvasion is different. And now if the microinvasive or the microinvasion or the microinvasive looks like low-grade serous carcinoma, they recommend just calling it microinvasive low-grade serous carcinoma. So to me, that takes some of the ambiguity out of the terminology being so close between microinvasion and microinvasive, that if you're calling something microinvasive, you're basically saying it looks like low-grade serous carcinoma. So if it doesn't look like that, use the other term. And I'm just putting this slide up here in case some folks haven't gotten their new WHO yet. But I think by putting the low-grade serous carcinoma term there at the end, it does clear that up somewhat. Though I still think, especially for trainees sort of approaching this topic for the first time, it can be complicated. So I think those are all the questions that we have. And I thank everyone for joining us. And I really thank all of our presenters who did a lot of hard work and did a really good job. Thanks, everyone.